Welcome, everybody. I'm just going to go ahead and get started. I'm Diane Ulmer. I am a spinal cord occupational therapist and the spinal cord injury program manager here at Madonna Rehab Hospital. And I've been an OT for, I don't know, 20 some years, and I've been here at Madonna for 17. So primarily my role is to oversee our spinal cord injury program from pre-admission. So sometimes I travel around the region when we're not in a pandemic and work with the trauma hospitals on just this, preparing our patients to come to rehab, visiting with families, helping them understand their injury, what this new life might look like. And then I oversee our spinal cord patients on our LTAC level of care, our acute rehab. We have a small transitional care unit or SNF, rehab day program, outpatient, and then our follow-up clinic. And I also call all of our patients at 6 months for a long-term follow-up call. So we're doing a little telehealth now for that too. So I wear many hats. Today, my hat was just be an OT on the floor and do showers and do therapy and do the fun stuff. So so we are going to talk today just about preparing a patient with spinal cord injury for rehab. And I wish more than anything that I could be there with you in person. I still cannot get used to talking to myself. I love to interact and I love to hear the challenges you're facing, which I know are many, many right now. So please, I'm very informal. I want you to get out of this hour what you need, not what I think you need. And so I try to put a little something in there for nursing and therapy and respiratory and everybody that's impacting the patient. So I think primarily we have nurses tonight, but please chat in if you're not a nurse and you're from a different discipline, so I can be sure to speak directly to you as well. Chat in any questions anytime. I'll try to check it because I really want you to get the information that you need tonight. So, okay. OT, yay, great. Okay, now I just have to advance my slide. There we go. So I don't have any disclosures. I'm going to open this up. Great, more OTs, yay for OTs. I don't have any conflict of interests. And we are providing contact hours for you tonight. Okay, and in order to get those contact hours, you need to complete the survey at the end, utilizing this link, which I believe is on your handouts and on the flyer. So let us know if you have any issues with that, or your contact there at the Med Center is probably the best. And do that before January 25th so you can get your contact hour. Okay, so our objective this evening is just that you will increase your knowledge of the interdisciplinary approach to prevent secondary complications. That's the theme of tonight, getting people ready for rehab and preventing secondary complications, and just increasing your confidence in transitioning that patient to acute rehab. Those are the objectives that we have to put on the special form, right, to get the contact hours. The real objectives I want to do is that tomorrow you're going to look at your patient differently. Tomorrow that you will look at more closely what happened yesterday and the last shift, and that you'll collaborate with your team even more. Rehab is all about teamwork, and so every facility and every floor and every facility works differently, but really if we're going to get these patients the best final outcome, we have to work as a team. And then that you'll look more closely at your patient's skin and bowel and bladder management plan, which is if you learn nothing here tonight, or if you remember nothing at all, those two things are the things that keep me up at night: patient's skin and their bowel health, because those are the things that make or break the quality of their life with a spinal cord injury. So I usually do a case study, but I just have a ton of content tonight. So just take 30 seconds and think of a recent patient with spinal cord injury or Guillain-Barré or transverse myelitis, and jot down 3 things that you had in your plan of care for that patient, or just mentally think of them, and things that you might collaborate with your teammates on or a different discipline on for this patient. And then hopefully by the end of the hour, you can add something to this list. I appreciate your time tonight. I know everyone is exhausted, beyond exhausted, right? Like we're just trying to stay alive, let alone learn new things. So big kudos to you for coming tonight. So every decision made, every technique learned by these patients not only impacts how they're going to do tomorrow, but their life 20 years from now. And I completely 100% believe that every minute with our patients impacts their final outcome. This is one of my former patients. He is in his late 20s, early 30s now. He was my patient when he was 17. He's a T10 paraplegic. So this is him scuba diving since his injury. He's recently become a dad. He's a farmer. He is an accountant. He's married, he's doing life way more than I do in life, right? And he's doing it because he's got great skin. He had great training. He had a great start. So please appreciate how powerful your influence is, truly. They are looking to you for hope, not looking to you for what you would choose for your son or your husband, right? They're looking for hope. And there is a lot of hope for folks with spinal cord injury. Absolutely. This is what you're used to seeing, right? On the left and on the right is what I'm used to seeing, which is a patient with a C1 spinal cord injury, so the highest level. He's ventilator dependent. He lives at home now with his family, and he has since finished his master's degree using eye gaze technology and voice activated software to do all of his classes. This is him playing the quad stick gaming system, and where he plays online gaming, does all sorts of crazy stuff that I can't do, and has a really high quality of life, very engaged with his family and his community, doing really cool stuff. Even though he can literally only move his eyes and a little bit of head movement. He drives his wheelchair via head array and does a lot of assistive technology, lots of environmental control. So I want to talk really quick about how fast recovery goes now, because it just sets the stage for how important every single day that you have with this patient is, and how every day that we have with them is. So they usually, on average, when we're not in a pandemic, are admitted to rehab within an average of 11 days. From getting pulled out of the ditch, being in 8-10 hour neurosurgery, right? Then they get to rehab pretty quickly. If they have Medicare, they usually get around a 12 to 18 day length of stay on acute rehab. If we can get them qualified for LTAC, then they get a separate length of stay, we know. And so we really use every single LTAC day we can to get them started on home modifications, assistive technology, get up in a power chair, really get them moving so that we can really talk to the family about their home and getting those modifications started, because 2 weeks is just not enough time to build a ramp, get all your doorways widen, train your wife how to take care of you, do rehab. So managed Medicare sometimes now is not even allowing for rehab, right? They say these individuals, this 66-year-old who just fell off a ladder putting up his Christmas lights last month, we're taking him down this month, fell off a ladder, is now a paraplegic, and he can just go to a skilled nursing facility. And so we are having to appeal those managed Medicare companies to show them that a skilled nursing facility is not the place for these folks. And the research shows all the secondary complications that occur when they are when they go to a facility where they're not specially trained in how to specially train them to live with a spinal cord injury. The average length of stay in rehab is 31 days. That's from the National Statistical Center. That's not Medana's average length of stay, but private insurances are also approving really 4 weeks, 6 weeks max, sometimes 8 if we're dealing with discharging them home on a ventilator, those sorts of things. So, or if they're starting to ambulate, you know, we have to appeal, and really convince them. So really, it's not long at all. So what they need to learn in this amount of time is an entire new way of life. If we put a layer of a wound on top of this, then it really delays everything, because it may delay them getting to rehab, which we'll talk about later, snowballs, all these other secondary complications, or they're in rehab with a wound with a limited sitting schedule. And so they really, this just gets condensed, and we really have to work even faster. So everyone matters to the final outcome. The folks who are intubating them, in the ambulance, your ED department, the trauma team, even the community who bought this young girl a car so that she could go to college. So everyone matters to their final outcome. And it matters starting the minute they enter the emergency department with their backboard. The length of immobilization on the rigid backboard is directly correlated with development of pressure injuries. And so making sure your facility has a backboard protocol, you're doing initial skin assessments, because some of these folks, right, are coming from rural Nebraska to you, and they maybe were on a backboard on an ambulance for minutes to hours to even get to you, right? So they maybe haven't had pressure relief for quite a while, depending on how long they were before they were even found, right? So getting them off the hardboard, if they are going to have to await transfer, and using those beanbag boards for pediatrics, because they have those big heads, which causes hyperextension. So those special pediatric boards. Doing that initial risk and skin assessment within hours is just crucial. This is not Diane's idea of how things should happen. These are all listed in the clinical practice guidelines that are at the end of my presentation. All the resources are there for you. So getting them on a pressure reduction mattress from day one, don't wait for a wound. Then it's too late, right? These folks have no sensation. They have no ability to reposition themselves to know that their coccyx is on fire, right? They have to have pressure reducing or low air loss mattresses. So just get that from the get-go and implement your protocols and standing orders, or whatever lingo that your floor uses for turning the patients and for pressure relief when they're up. So I know some trauma teams use turn teams, where this team is just constantly going room to reposition them so that the floor nurses and therapists can focus on other things. And when they get to the end of their list, they go back and start all over with repositioning. I know some teams use those little kitchen timers from the dollar store and just use the magnet to put them on their door frame so they're beeping. Electronic medical records can alert you, your watch, whatever. The patient's phone, the patient's watch, get them involved. And then also their incontinence management plan, get that going from the get-go for these patients, because we know if they have a neurogenic bowel and bladder, they are going to be incontinent, and we know that is also going to break down their skin. You know what? If I've learned anything in the last year of my career, it is more and more and more about nutrition. And I am not a nutrition therapist or a dietitian or anything. So I am not going to speak to the specifics of this, but I am going to speak to the literature, both in the spinal cord injury clinical practice guidelines and the pressure injury prevention clinical practice guidelines that are listed at the end. Malnutrition is our biggest enemy. And I just read the statistic that 30 to 50%, this is in the literature at the end, 30 to 50% of patients admitted to acute care are malnourished. like coming in, like already are malnourished. And so now we're putting pressure and neurological injury and surgery and no calories and all of this on top of all of it. And so, and they came in malnourished, which explains a lot. And malnutrition has a direct association with pressure injury, developing a pressure injury. Nutrition is the biggest component. So assessing their nutrition upon admission, we have to meet their protein, calorie, and fluid needs by day 3 and get that feeding going in the first 24 to 72 hours. Those lack of calories is what is putting them at such high risk. And if that's not possible, we need to figure out how we can get some calories and nutrition into them. I will leave this to the experts at your facility who know more about this. But if this is part of your plan of care or isn't part of their protocols to get nutrition in there right away, assessing this, then maybe that will be one of the new things that you can take to work tomorrow. BIs, brain injuries, have a high incidence with spinal cord injury because of the pure velocity that our neck goes through, right, in a crash or in a fall or whatever's happening. So just assessing the big picture for these patients. Do they have a mild TBI also? Because this is an important diagnosis for their final outcome. There's funding out there for folks with brain injuries that is not there for those with spinal cord injuries. And if they have a brain injury and a spinal cord injury, they are going to need every resource that is their right to have. And so we want them to be able to qualify for those if they have that diagnosis. So this can be hard to sort out, right? I mean, they are on a lot of meds, they are grieving, this is not easy. I'm just saying to pay attention to the big picture and consider the mechanism of injury and don't discount it as just meds if there is an issue. I wish I had lots of time tonight, but they did not offer me a 5-part series. Otherwise, I sure would have taken it because I have so many stories to tell. But this young man, he lives in Kansas and he's a C6 spinal cord injury. He started out on a vent and now he lives independently and he uses his track chair for hunting with his crossbow. And then this mount on the front of his track chair is where he mounts his camera. So he's also a wildlife photographer. So real cool guy. So these are just the things. He does not have a brain injury, but I wanted to bring his story up. So when you have a C6 spinal cord injury patient on the vent, just staring at the ceiling, you know what's possible for that level of injury. It is possible to drive by yourself, live by yourself, dress yourself, drag a black bear out of the woods with this track chair, right? What are you doing? Why are you doing that? I may or may not have messaged him that. Diane, you told me to get out there and live, right? Like, I wasn't really thinking about with black bears. Okay, right? Yes, live. Okay, good. Be safe. Okay. So we're going to talk about preparing for rehab and everybody doing everything we can to get hypotension under control, get that good pressure relief plan, and all those things to prevent a prolonged ICU stay, which is everyone's goal. One of the big things we can do is try to eliminate those respiratory complications. Those are huge for this population. It's the reason that our folks with spinal cord injury usually die, and it's usually why they get sent back into acute care. So you may be seeing them kind of frequent flyers, right, of folks that live in your community with tetraplegia. And yeah, this is happening in the weeks following their spinal cord injury when you're with them, when they're with you, and when they're with us. Because these folks do not have their respiratory muscles innervated. I mean, you don't get all of your abdominals until T10, T12. So even those higher paras that we think, yeah, they're fine. I mean, they're paraplegic, right? Nope, they still don't have the abdominals that they need to really cough well. They have decreased cough strength, especially our tetraplegics also. Reduced lung volume, poor thoracic expansion. That's why all those good chest wall stretches are good. Impaired breathing patterns are either you overusing their accessory muscles or using all of their diaphragm only, right? And they're not even pairing those patterns. And so digging out those Mary Massery skills, if you've never taken a Mary Massery course, since the pandemic, she's doing a lot of stuff online. Highly recommend it for anyone that touches a patient of any discipline, right? Because if they can't breathe, they can't function. That's the name of her course. It's real good. So what are we all are looking at? Interdisciplinary clinical observations, right? Documenting their voice quality. These are the things that are making us pay attention to, oh boy, they might be in trouble. They're not tolerating their position changes. You are probably going to be the person that picks up on their right lower lobe atelectasis, right? Because you're going to roll them on their left side for bowel care. And they're not going to say, Diane, it's kind of uncomfortable on my side. I don't want to do that today. No, they're going to be like, get me back on my back. Get out of here, right? No, I'm sure none of your patients say that, only mine. But right, they can't tolerate laying on their left side because you just shut down their good lung by rolling them on the left, and their right lung's filling up with gook, right? So you listen to their right lung sounds and you're like, compromise, something's brewing in there, right? So if they won't do side lying for you, they have to do side lying for 1,000 reasons, right? Their lungs and their butt are the two biggest reasons, right? Their skin and their lungs. And if they're not tolerating that, that becomes everybody's job. Why aren't they tolerating it? How can we get them tolerating it? Documenting those syllables per breath. If you can't work on anything else because they have to be immobilized or they're not feeling well, whatever, you can still be working on how many syllables per breath can they speak, and you can document progress with that. Watching those accessory versus all use of their diaphragm, positioning, how much O2 are they needing, and their respiratory rate. So in that same flavor of things, I just wanted to mention our team works with critical activities a lot. So we're picking a critical activity that is, what does this patient have to do in order to go to the next level of care? When we're in LTAC, what has to happen for them to go to acute rehab? If they're in acute rehab, what absolutely do they have to be able to do to be able to be at home, right? So in your case, I need to get them out of ICU to the step down, or I need to get them off of my floor to rehab, because we have, how many people do you have that need that bad? A lot, right? So what do we have to do? So one thing might be preventing vent-associated pneumonias, right? Because that's going to keep them in ICU or on your floor longer. Madonna won't take them. They're spiking fevers all over the chest, all over the place, right? What's happening? So what can every single person on my team do to impact the prevention of pneumonia, right? Well, nursing, you can be doing oral cares every 2 hours, or every time you're in there, right? Or as often as you can, just doing oral cares, because all of that bacteria sitting on their tongue and on their teeth, that's what's seeping down their throat, right? That's what's causing the infection. So all of that, so making sure they're well hydrated, making sure their head of the bed is up at 30 degrees, that they have access to their call light so they can let you know if they're not feeling good before they vomit and aspirate, right? And you can reinforce the communication with the team. Hey, can you do oral cares when you're going there? Therapy, what can you do? You can be modifying access to that call light to make sure that they can get to that independently. Duct tape is my friend, right? Getting some lock line and getting that oral suction taped onto that. If there's an infection prevention person watching, I didn't literally mean duct tape. I meant medical tape and things that can be washed and wiped down with the purple wipes. Infection prevention. Anyway, can they get to oral suctioning themselves? Do oral cares during your therapy also, because we cannot keep their mouth clean enough. That is going to prevent it, right? Make sure working on upright tolerance so that for swallowing to prevent aspiration too. Respiratory therapy, what can you be doing? Trialing the one-way valve, reinforcing that the head of the bed is at the right place when you're in there, doing oral cares, right? Everybody's doing oral cares. We heard you, Diane. Thank you. Yes, do them again, right? Family, what can family be doing? They're just sitting there waiting and wanting to do something. Teach them how to do good oral cares. Teach them not to put the head of the bed flat when they're on the ventilator. Teach them how to oral suction. Give them a job, not if they're not safe, right? But we can check them off and we can empower them with the skills they need. They're going to be with this person for the journey, right? So teach them early. Social work case management, what can you do? You come in to talk to them about their insurance benefits. I see that your head of the bed is up at 30 degrees. Perfect. That's where we want to keep it. Family, we need you to help us keep this person safe and healthy. This is what we're going to do. Are you with us, right? Setting those expectations, setting them up for education. Sometimes I get calls from the region like, we need this person to come to rehab. And I say their insurance company doesn't want to approve 3 hours of therapy in acute rehab because they're not doing any therapy with you. We can't do any therapy because we don't have all the fancy stuff you have. I hear you. We have to find something that they can do with you to show that they are tolerating therapy. And breathing is it. You can work on breathing and they need it. And so in all of these, if you guys want help with goals and how to relate this to functional goals and measurable goals, I am happy to talk with you about that too. And you probably already do a lot of this stuff. I can't see your faces, so I can't see you say, yeah, we got it, Diane, move to something else. So I'm sorry if this is not new information, but these are just some ideas. Doing that sustained how many seconds can they hold that? Doing the tapping, facilitation to increase that, taking a deep breath, counting to 15. Usually they get to 2, right? 1, 2, 3, 4, right? And then the next day, so you can set your goal a little bit longer and be working on that. Doing those expiratory trainers, working as a team. Respiratory, what can I be doing to reinforce what you're doing? I can't get them up today, so what else can we do? And breath stacking, all of those sorts of things. This is a whole course in and of itself, but I just want to send out that reminder because sometimes we get so busy. There's so much to do, so much to work on with these patients that sometimes we just have to roll it back to the basics. Making sure that we're pulling in speech early. I will never forget in those aha moments in your career, right? You never forget them. I was at a regional trauma center waiting to talk to a patient about coming to rehab. And the nurse said, oh, can you wait? Because speech really needs to do a bedside swallow eval. And I said, yeah, of course. So she comes out of the room. And so I'm just standing there. Somebody brings a tray into the room, leaves. About 10 minutes, 15 minutes later, the speech therapist comes and was like, I'm so sorry, can I quick do this assessment? And I said, yes, of course. I knew you were coming. We're not in a hurry. She goes in. A few minutes later, she comes out kind of pale. And I was like, is everything okay? And she's like, his wife fed him his tray. And I said, oh. And she said, they brought him a tray. We were so excited. So I thought he could eat because they brought him a tray. And he was a C4 injury and was not on any O2 that day. And that episode delayed him coming to rehab by 3 weeks because he aspirated, of course. And he came to us on 4 liters of oxygen and had a stage 2 coccyx wound. So we cannot over communicate enough with each other. Did anyone intend for that to happen? Absolutely not. Not the aide that brought it in, not the wife, but just empowering the patient and over communicating to them using our aided. Hey, I'm bringing you this tray, but I don't want you to eat any of it until the speech therapist comes, right? And so that could have saved him 3 weeks in acute care, and a lot of angst, weaning off the oxygen and healing that wound. Posture and positioning is so important. We're going to talk about this more as we go through, but just making sure we have a good plan. And I know you guys do this every day, but sometimes things fall through the cracks and you can't find the abdominal binder to help support those abdominal muscles, to support their diaphragm so they can breathe well, and to prevent that hypotension, or they're having a lot of edema, so you didn't put the TEDOs on because you weren't sure if they were going to cause a pressure injury, which is valid, right, when they become a tourniquet instead of a help. But just making sure that we do use those things to have a successful transition to the chair, so that they don't pass out, because then we all know they're anxious anyway, and then they're just real scared of the next time that they are going to get up. This is just a quick picture of somebody's posture in a power chair. You can see on the left, he's just slumped enough with enough posterior pelvic tilt that his breath support was worse, and his pressure mapping looked bad. And so then when we sat him up, got some lateral supports, supported his arms properly, lot better voice volume, lot better expiratory pressure, much better pressure relief. So just this subtle change can make a huge difference. So just want you to understand the effort that we put into positioning really pays off for the patient. So just really thinking before ever getting a patient out of bed, how are we going to do pressure relief? Because if we don't have a good plan for pressure relief, then it's a better plan to leave them in bed on their side. I don't know for sure what everybody calls these. I call them like a cardiac chair, pink Cadillac chair. I don't know where I even got that, but this foam is wicked bad on your backside, right? So in order to get, and I'm going to show you some pressure mapping pictures in a second, but in order to get pressure relief on this sort of chair, right, you would have to lay it flat, roll them to the side, let the old blood out, new blood perfuse, 1 minute to 5 minutes, roll them the other way so the other ischial tuberosity can get nice blood flow through, or you have to lean the patient all the way forward, right, so that you can feel that they have pressure relief over their coccyx, or lean lateral, leaving them all the way to the side to get their ischial tuberosity relieved, and then all the way to the other side. Ideally more than every 15 minutes, because in this chair, this $30,000 power wheelchair with a $500 Roho cushion on it, in this with laterals, in this ideal perfect scenario where they can tilt back 45 degrees to shift the weight from their backside onto their back so the blood can flow. In this scenario, the clinical practice guidelines say, sitting in this ideal piece of equipment, you have to do pressure relief every 15 minutes for at least 1 minute, right? So we have to have a good plan. Now, you don't have to have a fleet of power wheelchairs. That is not a realistic expectation for trauma hospitals at all, but we need to move towards using tilt and space chairs, which I think the Med Center is doing. I had worked with some folks on that some time ago. And this is where we have to channel our inner Matthew West. Are there any Matthew West fans out there? Right? His song, if not us, then who? Right? If not now, then when? Right? We have to do something, right? We cannot, okay, he's spreading the gospel. This is a different kind of gospel, right? this is what our patients need. So we cannot do things like we've always done them before, because we are practicing in a healthcare environment that is so fast, and we are tired, and everyone has staffing issues, and families are anxious, and patients are sicker, and they're surviving crazy things, right? We can't do things like we used to do them. We have to do them differently now. This slide, whoops, I thought I had a different slide right after this, which is why I was going that direction. But this slide is for the therapists out there, working on those key positioning things, getting that nice pectoral stretch for lung expansion, but also that iron cross position. So in your setting, I would just pull up, I usually just put down the bed rails and pull bedside tables up next to the person and put pillows out so you have a nice support under that shoulder, right? You don't want this to be painful at all. If they're already getting tight, whoops, then you might have to start at 30 degrees, 45, and then work up to 90. But if I'm ranging one arm, then I'll put this other arm on a stretch, right, with external rotation, because I tell you what, when those patients get to rehab, oh, those therapists want to hug you like crazy, because then they can get on the mat in a posterior prop position, right? Like this is the goal. We get them on the mat, external rotation, right? To start learning how to find their center of gravity and start working on slide board transfers. But if they have tight shoulder capsules, then, you know, we have to spend weeks undoing that, right? And then we don't have enough time for the transfer. So this is just a huge head start for the patient to be able to do this external rotation. Also great for their lungs. Tenodesis, I always have to throw this in there because it's just so important. So at level C5 or C6, C5, right, we only have biceps, but at C6 we get our wrist. So we get tenodesis grasp. So when God gave us a backup system, right? So when our fingers aren't innervated, but our wrist is, when we bring our wrist back, our hand naturally closes. When we bring our wrist down, our hand naturally opens. So we can pick up all sorts of stuff, our cell phone, our pen, we can put in contacts, we can change our baby's diaper, we can turn a key, everything, right? And we preserve this at C5 also because sometimes patients with C5 level of injury get stronger and become C6s, right? You might not be able to see the trace wrist extension at your level of care, but we might see it a few weeks later. So we want to preserve that. So we don't want to overstretch those. So we don't want the grandma to come visit and be stretching them like this, right? We don't want a physician just to blindly write a splint order for their hands. We have to really talk to them about what are we really talking about splinting. And so this splint right here would be the only sort of resting hand splint I would put on somebody who has the potential to have tenodesis. So when their wrist is down, we can straighten their fingers. So they should not be splinted like this, because then when they go to bring their wrist back, their hands are open, they may as well be a C5, right? They're gonna need, we just took away all their independence. So just making sure that the whole team is on board with keeping their hands closed when they're in bed, when they're sitting on the edge of the bed, making sure their hands are closed so that they're not sitting with an open palm with their wrist in extension, because that will overstretch all those tendons. If the patient's panicking, like, I don't want my fingers to get stuck like this. Oh, they won't be, because look, we can range them. Your joints are fine. And we can stretch those out. If your fingers start moving, we can stretch those out like that. That's why it's such a big deal to preserve the tension, because it can be stretched out so much. So we're not worried about contractures here. We're worried about overstretch. And so there's some other splinting things here that we could talk about a whole nother hour, right? Some tenodesis trainers and stabilizing the patient's wrist so that they can use a utensil and things like that. Okay, so sorry, circling back to skin, and my soapbox about pressure injuries in skin. These are statistics way pre-pandemic, and I was going to pull that article. There was just a really great article in the Journal of, I'll get it to you. I might have linked it below. A new research article showing how now that we are in a pandemic, how pressure injuries are going through the roof, right? Which is understandable because there are a lot of patients and not a lot of staff. And so, but even before all of that, 90% of, in this research study, 90% of these 500,000 hospital stays weren't even neurologic patients. They were acquiring pressure injuries just from being there from pneumonia, UTI, sepsis, respiratory failure. So it's a huge issue. So some degree of pressure injury formation occurs in 30 to 50% of patients in spinal cord injury within the first 4 weeks. And I can concur, this is about the rate we're seeing them come into Madonna, with about 35 to 40% of our patients have a significant wound, which significantly impacts their rehab. Also, they are at high risk for friction injuries, lifting their head of the bed up and down all the time, and these unstageable deep tissue injuries that look like this. This opens up into a 6 to 8 week problem, and then sometimes results in flap with more bed rest, and they sometimes don't even start true rehab for 6 months, and sometimes their insurance doesn't stick in there with them and they never get rehab. It's not inevitable, it is preventable. It is not inevitable, it's preventable. So communicating skin breakdown quickly within your team, looking at the whole person. What's their nutrition? What's their incontinence plan? What's their repositioning schedule? Completing a skin assessment every time you reposition and documenting it so you can catch the first stage of redness. Looking at interventions and documentation. What did the staff yesterday see, and is it worse or better today? Get your wound experts in there right away and regularly. Reposition every 2 hours in bed. Side lying is the absolute best for them, because good skin equals good rehab, right? We have to educate the patient and we have to get good buy-in if they are going to if they're going to be getting in the pool, getting in the Locomat, getting in the exoskeleton, all of those things. So repositioning every 15 minutes when they're in a sitting position, and every 2 hours when in bed, using pressure relieving mattresses and cushions, nutrition, and figure out if they are refusing side lying, address the shoulder issue. We take pictures. Every human is different, right? Every human's different. So taking pictures and of how they're comfortable, how you're doing it, and then hanging it up so the whole team knows, or email it out, or however your team best communicates. Teach the patient how to direct their care. If your shoulder feels best like this, you're the most consistent person in your care. You have to be a good advocate for yourself. Tell the human that is coming in tonight, who wants to do the absolute best job for you, how it feels the best, because then you'll be able to tolerate it, right? And protracting that scapula when they're in side lying is your ticket, right? Making sure that's protracted is key. Sometimes I have to use pressure mapping pictures to convince my patients who don't want to reposition. So this is a pressure map. If you aren't familiar with it, it's just like a really thin black mat, literally, that's hooked to a laptop. We put it in their wheelchair, on their cushion, or we put it in their bed under their gluteus maximus, and then we show them the degrees of the pressure under their bones, measured in degrees of mercury by this this little scale here. So blue is pressure is equally distributed. So they're laying flat, supine in bed. So this is their these are their thighs here, their coccyx is back here. So, yep, looks good because their weight is equally distributed all over. You raise the head of the bed to 30 degrees, whoop, peak pressure at their coccyx, right? Well, Diane, you just said they have to have their head of the bed at 30 degrees, right? So they don't aspirate. We all know this. This is not new information, but they can be on their side at 30 degrees, right? So making sure that we're cognizant when we are leaving them like this at 30 degrees, that they have so much pressure underneath their coccyx right here. If we raise their head of the bed to 90 degrees for them to eat, wow, right here's where might as well just tell the wound team where the wound's going to be, right? Like this is peak pressure. If they can eat sitting up in a chair, that's better. Are you crazy, Diane? Right? These people, I get it. They're critical, they're ill, they haven't been out of bed, let alone able to eat in bed, but that's the goal, right? Or if this is a necessary evil that they have to sit up at 90 degrees, just be cognizant that this is peak pressure on their coccyx with the head of the bed at 90 degrees. And as soon as they've digested well, they have got to lie on their side and let that area perfuse with fresh blood. Otherwise, they will acquire wound, especially if they have incontinence, especially also if their nutrition isn't optimal, which it's not, because they don't feel well and they have a lot of critical things going on. This is what the pressure mapping looks like in full side lying with the head of the bed at 30 degrees. Okay, so that's great. It's a great option. Okay, quickly, I talked too long. We have to cover bowel and bladder in 10 or 12 minutes. So if you ever want to talk about this topic in more in depth, I would be happy to grab a nurse and grab our pelvic floor therapist and dig into this deeper. I'm just trying to do high level, like, do we have the protocols we want to help us? Are we keeping all this front of mind when we're also dealing with COVID and COVID, right? So I get it, it's a lot, but bowel management is key to getting these people out of your hospital and out of the ICU because their neurogenic bowel, they develop an ileus so quickly, impaction, which can cause a bladder rupture. They may have internal injuries also affecting it, but their spinal cord injury alone affects their colonic motility. So patient anxiety about rolling side to side and their compliance with that also relates directly to their bowels. They know when they have to move, they're going to be incontinent and they don't want that. They're mortified, right? And so really important that we're getting them on a bowel management program so that they're also more compliant with repositioning. That bowel distension we know leads to poor evacuation, and poor evacuation, is going to lead to vomiting, gastric residuals, poor lung expansion. I did a lot of training at a trauma hospital, like a half-day workshop, and they called me about 6 months later and said, you know, we have this lady that is level C5. She's been living in the community. We see her every winter for pneumonia, and she has a trach long-standing, but she came in, we put her on the vent, we resolved her pneumonia, and we can't get her back off the vent. And I had done some training with our pulmonary program manager, and they're like, what's the deal? What else can we try? So we're like, try this, try that, try this, try that. So we did, we tried it all. You taught us, we tried it. And so finally I was like, what could be the problem? And I said, well, when was the last time she did bowel care? Crickets. I'm like, when did she admit? 6 days ago. Okay, do bowel care. She was on the vent and they didn't have a one-way valve. They didn't have PMV valves at that facility. And so she couldn't direct her care and tell them, I need you to do my bowel care and this is how I need you to do it. So they did her bowel care and she was home off the vent 72 hours later. She was so full of stool that it literally decreased her lung expansion, and there was no pneumonia, but she didn't have enough room to breathe. So really, really important. to do that bowel care, also to reduce the incontinence, to prevent the skin breakdown, because dirty, wet skin, we know, breaks down faster. And when their bowels are out of control, it delays them being able to get in the pool and the locomat and all those things that are so critical, especially if they have central cord syndrome or an incomplete injury and they are a potential ambulator. We really need to use those tools to maximize their neuro recovery. So the clinical practice guideline was just updated, so that is super. And so the whole protocol is listed out here. And there's also a nice booklet. They didn't update this, but it's still relevant, and it's written for the patient, and that can be downloaded for free at pva.org. So it just helps the family understand the bowel care program, and this is a lifelong thing that they're going to do every single day or every other day for the rest of their life, if they have a complete injury, and sometimes if they have a complete also. So good for them to be understanding this. So how does your team address it? Some trauma hospitals initiate incontinence rounds or care planning surrounding this. I definitely have worked with some teams who needed some extra education, and I'm happy to collaborate with you guys on what other facilities have done, because I have gotten some serious pushback on this. Like, we do not have time to do this kind of program. And really, when you do a time study, and one of the trauma hospitals in Kansas did this, it saves more time because you're not in there constantly cleaning them up. And so the protocol, I know we've shared with you guys, but I don't know if you've heard me speak before, or if every floor has these protocols or not, but just for those upper motor neuron injuries, you know, you're looking for soft form stool, and you're doing dig stim every 10 minutes with or without these stimulants. The magic bullet and the mini enemies and the mini enemies plus are what the clinical practice guidelines suggest to use for medications. They work faster, they work more effective than like a Zolcolax, bisacodyl suppository that can take a long time and end up with some mucousy problems later. So, and digital stimulation really, you know, is just inserting that lubricated gloved finger and going around that anal sphincter, you know, 10 or 20 seconds to stimulate that internal sphincter and to relax the external sphincter so the stool can come out. Just want to monitor for signs of autonomic dysreflexia, of course, but a lot of your folks are probably still in spinal shock, so probably won't be a big deal there. And then, of course, those folks with lower motor neuron injuries, those cauda equinas, they have a flaccid bowel, so or flaccid sphincter, so they're going to need manual removal, so their stool should be more firm, and so those are the folks therapies coming in, and every time they stand them up with their walker or to transfer with the slide board because they're higher level, and they valsalva and bear down, then they're incontinent and the stool just falls out because their sphincter is flaccid. So I get it. You guys have a lot going on, but just if you don't have protocols or you're not doing this for all of your neurogenic bowel patients or your spinal cord patients, just consider it, because if not us, then who, right? It is the gold standard. It is the clinical practice guideline for these folks, and it will save their skin, it will save you time, and it will decrease their days in acute care. Bladder management, also critically important for these folks to decrease their risk for kidney influx. I want to avoid CODIs as much as you do. Everybody wants to avoid CODIs, but we cannot avoid CODIs at the risk of ruining their skin because they're incontinent all the time. And we have to manage the bladder volumes because overflow is not okay. So those folks who don't have an indwelling Foley catheter, and we're either using, and they have a neurogenic bladder, that's what I'm talking about, these folks with spinal cord injury, or someone with a neurogenic bladder who we're using either like a PureWick or like a wrap to absorb it. Those folks, their bladder is filling up so much that it cannot take one last drop. It's either going to reflux up into their kidneys and cause some upper tract issues, or it's going to spill out, overflow, and just gush out, right? And so if they cannot start a stream of urine volitionally, then we have to manage them either with a Foley catheter or intermittent catheterization, and we have to manage their bad bladder volumes because over distension of the bladder correlates directly to long-term voiding impairments. And we have patients who have incomplete spinal cord injuries who have some use of their bladder, but if it's been over distended, we can't get that back. So our pelvic floor therapists work with them. But if it's already been over distended because of high bladder volumes, over 300, 500, 800, some patients come to us on an ambulance and we cath them, we get 1,000 out, right? That is damage. And then they're going to have a UTI because, all those little micro tears in the muscles from that over distension, that's where the bacteria is going to grow. And so maybe Save Ducati definitely bought them a UTI and really in fact impacts their long-term ability to gain bladder control. And when they survey thousands of patients with spinal cord injury and ask them, what do you want to get back? Everybody hypothesizes that they are going to say, I want to walk. But every research study that you will find says, I want my arms back. Some say arms back and then bowel and bladder, and some say bowel and bladder first and then arms, depending on the research study and how many people were in it. But usually it's bowel and bladder because they say, you know what? I can go to Disneyland with my kids in a wheelchair. That's not a problem, but I can't go if I'm incontinent of bowel and bladder, right? That's what's keeping me at home. That's what's paralyzing my life. So this is just so critical. And we work on this so hard in rehab. And so I'm not trying to put a monkey on your back. I'm just saying it is so worth the time to keep their bladder volumes low and keep them safe and give them the best chance at the final outcome. So those intermittent catheterizations programs should usually be every 4 to 6 hours, but usually if we're hydrating them well enough, they're going to need it every 4 hours. And we need to try to keep their bladder volumes under 500. And that's from the American Urological Association, and all those references are below. And I'm not trying to get hung up on numbers with these two slides. I am not a urologist. I don't play one on TV. I am strictly pulling numbers out of the literature, and it varies a little bit. It does. So whatever your docs want to do, great. I'm not here to put numbers on things. I just want everybody's awareness to be heightened. If this patient is incontinent, what are we doing to manage it? Because that will help us manage the skin and help us manage the future infection. And then this is just the clinical practice guidelines for spinal cord injury that says folks with spinal cord injury can and should have an indwelling urethral catheter or a suprapubic catheter if they can't cath themselves, if they don't have the cognition to manage that, if they have elevated detrusor pressures, all of those sorts of things. So I just put this in there for reference because this is a hot topic in healthcare for sure. The rest, we're out of time, and I want to be cognizant of your time to get back to the floor or get to your kids or get to your self-care, whatever you need to do. So there's some slides here at the end that is just about preparing our patients for the psychological transition from ICU to a different floor, from a different floor to an LTAC, or from an LTAC to an ARU. Just coping looks different for everyone. And really, I quoted some references at the end that, when they survey families and do research, families just want clear information. They want the truth about the situation, whether they can understand it or hear it or accept it or not. That's what they say they want, right? Depression is real. Denial is part of the process. It's okay. They will get through it. And they're protecting themselves. We got to do what we got to do to get out of bed in the morning, right? So just treating that depression aggressively and helping them get everything back, helping them understand that terminology, helping them understand their insurance benefits will help them so much. And then you can have this for your reference. What are you going to work on in LTAC? We got to get you there so we can get you sitting up more and start that weaning off the ventilator, get you doing an eye or a head tracking software so that you can communicate. You can do your own online shopping, right? And this is a gentleman with ALS with just a minimal head movement that he used with that little reflector on his head to communicate with the computer. So he had full communication ability and full access to the internet with that. Acute rehab, yep, we're going to go back out into the community as soon as the numbers go down, right? So wear your masks. But we have a lot to do in acute rehab, right? And so you're going to do very well. Get you back to school, get you back to volunteering, to all your life roles, right? This is my scuba diver kid on his farm. So yeah, get you back to living, right? Does anybody have any questions? I did go over, as I always do. My email is on the first slide. I welcome you to email. I love the work you do, and we are so thankful for everything you do every day. So I really want to collaborate if we can. See, I see a chat. You're very welcome. Thanks for your time. Don't forget to fill out the evaluation so you can get your contact hours, and reach out, really, if we can do anything to help or collaborate. You guys are incredible getting to work every day in this environment. I respect you. I can't even tell you how much Madonna respects you and appreciates all your hard work. And our patients love you too and respect you and are so thankful for you. And we don't do a good enough job telling you how much they remember you and are thankful for you. So please know that they are. So I'll just wait a few minutes if anybody has a question. You're very welcome.